Good evening, all. Welcome to today's webinar on assessment of the right ventricle on echocardiography. So, the speaker of the day is Dr. Sravan. Dr. Sravan has completed MBBS, MD in respiratory medicine and DrNB in cardiology, with expertise spanning both cardiac and pulmonary medicine. He has extensive experience in echocardiography, coronary care, pulmonary hypertension, heart failure management, ventilation, and critical care. A gold medalist in general medicine and pharmacology, Dr. Sravan combines strong clinical acumen with passion for medical education, bringing valuable experience in both patient care and academic teaching. Over to you, Doctor. You can start the session.
Yeah. Can you give me the video access? I have to show them the heart first.
Just a second, Doctor. Video, you can run the video on video, Doctor.
Yeah, it wasn't showing. Host has disabled. That's why.
Just a second. You can start now.
Yeah, am I visible to that?
Yes, Doctor, you're visible.
Yeah, okay. I think everyone getting image of the heart, which was I'm holding in my hand, right?
Yeah, we are able to see.
Yeah, yes. Thank you. See, generally for assessment of right side of the heart, generally cardiologists or some they will neglect about right side of the heart compared to generally will give more attention to the left side of the heart compared to right side of the heart. Generally, you see, I'm holding the heart in my hand. See, right side of heart has three portions, like smooth muscular inflow body. This is the smooth muscular inflow body, and this is the outflow region, and this is the trabecular apex. And generally, while proceeding for CABG for any coronary artery bypass grafting surgery, when we open the chest, first we will see the right ventricle. Okay, and it has three parts. See here.
Doctor, I think you need to lift that art things.
Yes.
It's not,
yeah.
only.
Okay, fine. Now you are getting right.
It's fine now, Doctor.
Yeah. It has three components. Like, see here, it was smooth muscular inflow body and trabecular apex region, the outflow region. Right ventricle has three parts. It was generally thin pyramidal structure which wraps around the LV, left ventricle. Okay. These are the generally the views we have to see in the 2D echo for right side of the heart. The first image which was showing was parasternal long axis view. It has see LA, LV and aorta and RV. Generally we will see the first image. We will see right ventricular outflow tract and parasternal long axis view of the RO inflow view. Generally we will see LV, right ventricular outflow tract and pulmonary artery. This I have taken from American Society of Echocardiography Society article, and we have to image parasternal short axis view of the RV outflow view, where we will see RV outflow tract. And there was parasternal long axis view of the RO inflow view. These are the different views where we have to image the right ventricle. Okay.
Doctor, can you be? I mean, sorry to interrupt.
Yes.
Can you talk with bit near to the speaker?
Yeah, you're not getting adequate voice.
Yeah.
Yeah. Now you're okay.
Yeah. Now it's fine, Doctor.
Okay. See, these are the different views for the right ventricle. They're generally for any beginner to start 2D echo for right ventricle. Generally, we'll proceed from parasternal long axis view. Then we'll go to short axis view. Then we'll go to apical 4-chamber view. Then we will go to apical 5-chamber view. These are the different views for seeing the right ventricle, like parasternal long axis view. And generally these things you have to practice by sketch so that you can remember while doing 2D echo. See, generally, the image which I am showing were the normal morphological structures. While assessing RV, we will see these normal morphological structures. The first image which was showing was parasternal long axis view. There was some in the arrow. It was showing some muscle tissue. What we call it as moderator band. Sometimes we may confuse with some. What we call some clot or some mass, we will confuse with that. Generally we will differentiate morphological RV from morphological LV by seeing moderator band. See, there are three views here, which was first image was parasternal long axis view, and middle image was short axis view, and third image was apical four chamber view, which was showing moderator band. These are general morphological structures. uh, for everyone we will see this moderator band. Generally will confuse beginners will confuse moderator band with some mass or some clot. And secondly, this is the normal anatomical structure which was showing Chiari network crossing the right atrium. This was the embryological remnant. This was a normal morphological variant present in right atrium. It should not be confused with some thrombus or some mass or some other foreign structure. These are normal structures present in RV. This was moderator band, and this was Chiari network crossing across the right atrium. After seeing, generally we'll systematically analyze right side of the heart. First we have to go to right atrium. We have to take the dimensions of the right atrium in two different ways, and we have to see whether right atrial enlargement is present or not. See, here see, I compared with two images. One which was on my in your screen, on your left side was normal structure. On your right side it was abnormal. Like right atrium was enlarged. See here, this was the echo showing right atrial enlargement. While assessing right side of the heart, first you have to systematically you have to analyze first RA, then RV. Whether any RA enlargement is present or not, we have to see. The RA is the best imaged. Generally, RA will assess in apical four chamber view. Normal threshold for RA was less than 19 centimeters square. Then after measuring the size of RA, then you have to measure the thickness of the RV. Generally, RV is thickened in when there is pressure overload, like when there is high pulmonary artery pressures, we will see PAH. So increased RV wall thickness can be seen in infiltrative and hypertrophic cardiomyopathies, measured at the end diastole by M-mode or 2D echo from the subcostal window, preferably at the level of the tip of the anterior tricuspid wall or left parasternal windows. When there is significant thickening of visceral pericardium, measurement of RV wall may be challenging. See here, this was the subcostal window. So generally we are seeing here LV and RV, and we applied M-mode. M-mode showing uh, M-mode cut showing the wall of the right ventricle which was thickened. And after assessing the thickness of the RV, we have to go to the RVOT size. Generally we'll best RVOT generally we will view from left parasternal and subcostal views. Size of RVOT should be measured at the end diastole or at the QRS deflection. In plaques view, proximal RVOT can be measured. See here. the first image showing plaques view, parasternal long axis view, where we are taking the RVOT, a measurement. End to end we have to measure. And what is the use of taking RVOT measurement was, generally there is arrhythmogenic right ventricular non-compaction. Generally we will see there will be task force criteria. For that we will measure the RVOT measurement. RVOT measurement generally will take in the two views, like parasternal long axis view and parasternal short axis view. In parasternal long axis, here we will see it is more than 32 mm, and parasternal short axis view at the level of aortic wall, see it was more than 36 mm. So in ARVC, arrhythmogenic right ventricular compaction, generally there is dilated RVOT. After that, we have to measure the RV dimensions. RV dimension should be measured at three levels. See, at the level of tricuspid annulus, RVD1, at the level of mid cavity, and distance from tricuspid valve annulus to the RV apex, we have to measure. See, generally if it is RV dilatation at the basal level is more than 4.2 centimeters, at mid level it is more than 3.5 centimeters, at longitudinal level it is more than 8.6 centimeters, then we call it as dilated RV. Generally RV dilated in conditions like volume overload, like atrial septal defect. And this was the image showing normal apical four chamber view, which was showing LA, LV, mitral valve, RA, RV, and tricuspid valve, and interventricular septum and interatrial septum. See, in this image what I am showing was, this was the one of the echo image which was showing Epstein's anomaly. Epstein's anomaly is nothing but one of the congenital anomaly, which was cyanotic congenital heart disease, where tricuspid valve is displaced, malformed, and displaced towards the apex of the heart. So there will be right ventricle is atrialized. There will be atrialized right ventricle, and most common patient will present with SVTs, like supraventricular tachycardias. So this is one of the image showing Epstein's anomaly. Generally, see in normal apical four chamber view, the valves like mitral valve is more towards apex compared to tricuspid valve. But here in apical four chamber view, see the tricuspid valve was more towards the apex. So there will be atrialization of the right ventricle. This was the Epstein's anomaly. See, after seeing structural abnormality, generally we will proceed with like functional assessment of the RV. Generally, RV functional assessment, we can see a fractional area change, or we can measure like RV LV ejection fraction. We can measure right ventricular ejection fraction, and we will see TAPSE, and we will see tissue Doppler imaging. Like functional assessment can be done in 3 or 4 different ways. Uh, Generally, fractional area change will calculate by apical four chamber view. You have to take the area at the end at the diastole, at like end diastolic area, and you have to take the area at end systolic area. And see, in apical four chamber view, the image showing where you have to take the area at end systole and end diastole, and you have to apply this formula. Sometimes the advanced machines will give AI enabled echo machines will give directly FAC, fractional area change. Even previous old echo machines also will give fractional area change. Generally, normal fractional area change will be more than 35%. And generally, even beginners will generally, easiest way to measure right ventricular function is TAPSE. or tricuspid annular motion. Generally, how we'll see TAPSE was, you can see, you can go for apical 4 chamber view, and you have to keep cursor on tricuspid valve, one of the tricuspid valve, and you have to apply M mode, and you have to by placing M mode cursor through tricuspid annulus, measure the amount of longitudinal motion of the annulus at the level of peak systole. Generally, TAPSE should be more than 16 mm. If it is less than 16 mm, there will be RV dysfunction. See here, we have taken apical 5 chamber view, and the M mode was applied over the lateral annulus of the tricuspid wall, and we measured TAPSE. TAPSE is simple, less dependent on optional image quality, and reproducible. Does not require sophisticated equipment or prolonged image analysis. And disadvantages was, it assumes that the displacement of single segment represents the function of the complex 3D structure, and it is angle dependent, and there are no large scale validation studies. Finally, TAPSE may be load dependent. It is generally beginners, when we go for cardiology training, generally we'll start with TAPSE for assessment of RV function. It will be very easy. Even beginners can, if one can get the apical 4 or 5 chamber view, they can easily put the cursor, and you can apply M mode on tricuspid annulus, and you will get the TAPSE. And tricuspid, other thing was tissue Doppler imaging. Same thing, in tissue Doppler imaging, you can get apical 4 chamber view, and pulsar wave Doppler sample volume is placed in either tricuspid annulus or middle of the basal segment of RV wall, and you can get S prime velocity. Generally, S prime velocity is normal, and generally it is more than 10 centimeters per second. Simply, there was a software like tissue Doppler imaging. You can get an apical 4 chamber view and apply. You can place a sample, tissue Doppler sampling on the tricuspid annulus or middle of the basal segment of the RV free wall. After assessing function of the right ventricle, generally we have to measure right ventricular systolic pressures, what we call it as RVSP. Some people may directly go to IVC measurement. Generally, we'll get IVC in subcostal view, and you have to apply M mode over the IVC, and you have to measure the distance in the IVC. Generally, see here, open the IVC to the fullest, perpendicular to vessel, apply M mode. You have to measure inner to inner diameter, and you have to ask the patient to sniff. Generally, for measurement of IVC, M mode is preferred. And don't measure at the level of RA junction. Generally, when person generally IVC will collapse 50% with respiration. If it is less than 50% collapse, it was abnormal. Or yes, we can ask them to hold the breath also. Generally, if IVC size, generally it was 2.1 centimeters. If it is more than 2.5 centimeters, sorry, 2.1 centimeters. If it is more than 2.1 centimeters, it was abnormal. Generally, IVC size will correlate with the right atrial pressure. If IVC size is normal and there is 50% collapsibility, there is 3 mm Hg of right atrial, mean right atrial pressure was 3 mm of Hg. And if it is IVC size is normal and collapsibility is less than 50%, it is 8 mm of Hg. And IVC size is more than 2.1 centimeters and less than 50% collapsibility, it is 8. And if size is more than 2.1 centimeters and collapsibility, if it is more, it is abnormal, less than 50%, it was right atrial pressure was approximately 15 mm of Hg. Generally in ICUs, generally they will measure IVC size to monitor the hydration status. Generally, it will be helpful in for critical care people to assess the hydration and even to assess the right ventricular pressures and for even for monitoring for fluid balance. Generally, will assess IVC. Generally, for in general in cardiology, will assess IVC for to increase or the decrease the dose of diuretics in heart failure based upon IVC size, based upon his fluid overload status. Will like either oral or IV to escalate the dose of diuretics. Generally, will use IVC measurement. After that, general will proceed for right ventricular systolic pressure measurement. Right ventricular systolic pressure generally will take apical four chamber view, and we will see tricuspid regurgitation Vmax. See, I will show clearly. This is the apical four chamber view, and you have to on the color Doppler, and there will be tricuspid regurgitation, and you will get TR jet, and after that we have to measure TR Vmax. TR Vmax will measure, and generally some echo machines will give you directly the TR Vmax. After that, right ventricular systolic pressure generally will be calculated with Bernoulli's equation 4 into TRV max whole square plus right atrial pressure. If we get like TRV max like 3, 4 into 3 whole square plus right atrial pressure. Based upon the TR jet velocity, based upon the RVSP, we will classify pulmonary artery hypertension. If RVSP is less than 35, it is normal. If it is 35 to 50, it is mild pH. Generally, if it is 51 to 70, we will classify it as moderate pH. And if it is more than 70, we will classify it as a severe pH. Like you have to get apical four chamber view, and you have to on color Doppler, and color Doppler should be placed at the level of tricuspid valve, and you have to see TR jet Vmax, and you have to apply Bernoulli's equation. Generally, modern echo machines will directly calculate RVSP if you place color Doppler, and if you place continuous wave sampling over the tricuspid valve. Generally, they automatically it will calculate the RVSP. RVSP generally useful will get it by like from Bernoulli's equation, like 4 into TRV max plus right atrial pressure. And after that, generally for right ventricle, generally will see for any signs of pulmonary embolism. See, what we'll see was in acute pulmonary embolism, there will be increased RV size compared to LV size, and there is the displaced interventricular septum towards the LV, and there will be McConnell sign uh, like like hypercontractility of the apex, and lower contractility at the level of base, and there was a tricuspid regurgitation, and there is increase in RVSP, elevated pulmonary artery systolic pressure, and there is decreased TAPSE, and decreased S prime velocity, and generally there is decreased pulmonary artery there will be a pulmonary artery mid systolic notching, and decreased free wall strain in the echo imaging. See, I will go one by one. Generally, when there is high pressures or when there is pulmonary embolism, high pressures of the pulmonary artery, the RA-RB will be dilated, and when there is high pressures, the septum will generally septum is towards RV compared to LV, because LV pressures are high compared to RV pressures. When there is pulmonary high pulmonary pressures, the septum generally shifted towards the LV, and there will be tricuspid regurgitation, and there will be TAPSE. See, I will get you one by one, and see what is pulmonary acceleration time. Generally, pulmonary acceleration time will get by short axis view at the level of aortic valve, and pulse wave Doppler should be placed over the pulmonary valve. Doppler should be aligned over the flow of the pulmonary artery, and sample volume should be at the level of annulus. Generally, we will get notch like there will be smooth curve when there is uh, when there is pulmonary embolism. There is the decreased pulmonary acceleration time. I will show you clearly. Generally, pulmonary acceleration time indicates one of the indirect measure for pulmonary vascular resistance, and decreased pulmonary acceleration time generally noted with increased pulmonary resistance. Generally, it is more than 120 milliseconds, and if it is less than 120 milliseconds, when there was notching in the pulmonary acceleration time, chances of pulmonary embolism was more common. And pulmonary acceleration time is also an indirect measure for measuring pulmonary artery hypertension. When sometimes we may not get tricuspid regurgitation to TRV max, to measure TRV max, then you can go to short axis view at the level of aortic wall, and you can place a simple uh, pulse wave Doppler uh, or the pulmonary valve, and you can measure pulmonary acceleration time. It was one of the indirect measure to see pulmonary hypertension. See, and you can assess. See here, you can see pulmonary artery, even pulmonary artery bifurcation, and you can see the thrombus. There will be saddle pulmonary embolism, and there was the thrombus in the left pulmonary artery. And there is a ways to differentiate acute pulmonary embolism from chronic pulmonary embolism. In acute pulmonary embolism, generally there is a right heart like thrombus in RA or RV. In chronic, generally will not see thrombus in chronic thrombo, like chronic pulmonary thromboembolism. And in acute thromboembolism, there is no RVH. In chronic thromboembolism, there is RVH, right, like right ventricular hypertrophy. Generally, we will get it by subcostal view and placing M mode over the right ventricle. And generally, in acute pulmonary thromboembolism, the thickness will be less than 5 mm. If it's chronic, it is more than 5 mm. And even for tricuspid regurgitation pressure gradient, in acute it is less than 46, and it is chronic it is more than 46. And pulmonary artery acceleration time in acute it is generally less than in between 60 to 80, less than 60 to 80, and in chronic it is less than 1.105 milliseconds. And McConnell sign generally present in the acute compared to chronic, and like RARV enlargement is also generally most common in chronic compared to acute. And visual assessment of the ventricular septal curvature looking for D-shaped pattern in systole and diastole should be used to help in diagnosis of RV volume or pressure overload. In short axis view, even at the level of papillary nasal level or at the level of mitral wall level, generally we'll see round like round LV and interventricular septum and RV, and you can see interventricular septum. Generally, in RV pressure overload, there will be septal shift throughout the cardiac cycle, which will be most marked distortion of LV at the end systole. In RV volume overload, The septal shift occurs predominantly in mid to late diastole. You can this requires some experience. And generally for assessment of RV, sometimes you may encounter some mass like right atrial myxomas. You have to differentiate mass from thrombus. Generally, mass will have stack, and for thrombus there was no stack. There is no attachment structure. This was the one of the image showing right atrial mass, most common right atrial mass myxomas, and this was thrombus. Generally, most common in DVTs and most common in malignancy patients. And one other structure will encounter in assessment of right atrial right ventricular. Generally a cardiologist will generally they will place pacemakers in the right side of the heart. You can see sometimes leads in the RARV, like when cardiologist place some pacemaker or some AICD or some CRTD. Generally lead will be there will be like single chamber pacemakers and dual chamber pacemaker. Generally there will see leads in the in single chamber. Generally we will see single lead. In dual chamber we'll see like two leads, in one in RA and one in RV, and CRTD also will see the leads. And you have to assess the tricuspid wall whether any vegetations. Generally most common in vegetations when we keep IV lines, generally vegetations are most common in in endocarditis. Generally vegetations are associated with some tricuspid regurgitation, and generally vegetations involvement of tricuspid infective endocarditis of tricuspid wall, generally it was very rare compared to left side of the heart. So, in summary, generally for assessment of the right side of the heart, first you have to while doing any 2D echo, first we have to go with parasternal long axis view. Then even for assessing LV or RV, you have to go with parasternal long axis view, like then parasternal short axis view, then apical 4 chamber view, then apical 5 chamber view, then subcostal view. You have to go in a systemic manner. First you have to assess RA size, then you have to assess RV size, then you have to see whether any mass or any thrombus in the RA, any leads in the RA or RV. Then you have to assess tricuspid wall. If any by placing simply by placing apical 4 chamber, you can get all these details like any RA enlargement, any RV enlargement, or any RVH, or any lead, or any mass, any like any vegetation over the tricuspid wall. And after assessing RA RV size, then you have to go for RVH measurements. Simply visual assessment, some people can, experienced people can tell RVH is present or not, or you can place, by placing M mode you can get RVH. After that you have to assess RVOT size, like any increase in the RVOT size. Generally RVOT size is increased in the arrhythmogenic right ventricular ARVD or ARVC. Then you have to go for pressure measurements, like some people will go for a right ventricular RVSP, or by placing a tricuspid regurgitation by measuring TRV max. And after that you can serially measure the IVC, and whether it was 50% collapsing with respiration or not, you have to see. And you have to measure RVSP. Based upon that you can grade mild, moderate, severe PAH. And after that you can see the RV functional assessment, like a fractional area change, or you can measure LVF like RVF like LVF. And you can place a tissue Doppler, or you can measure TAPSE. Generally the person who are the beginners, generally for assessment of RV function, they will start with TAPSE. TAPSE is easy to measure, and uh, it will be for starting for assessment of RV function. TAPSE is the most used by even by critical care people, and even for beginners, like even beginners in the cardiology training. General TAPSE is most easy to measure compared to all other measurements. Even in my training, first I will start with the TAPSE, so it will be easy. And first, you if you want to start for assessment of RV function, better to start with TAPSE. And after that, any signs of pulmonary embolism, like you, if you generally will assess pulmonary artery in parasternal short axis, you like you can get at the level of, see, I'll show you the images. See here, third image. See the parasternal short axis with the RVA outflow tract. Generally, if there is a pulmonary embolism, sometimes even you encounter clots over the pulmonary artery. You can see the pulmonary artery in parasternal short axis view at the level of RV outflow tract. So, you, based upon your convenience, based upon your experience, you can start seeing right ventricle. And generally right ventricle is somewhat generally cardiologists or some guys will give less importance compared to left ventricle. So I think we have to focus more on the right ventricle. I think uh, for assessment of the fluid status, I think right ventricle is more important compared to left ventricle. And you see, in what generally you will measure situations like after like IT fracture, post IT fracture, orthopedic surgery was done and the patient was immobilized for a few weeks. And sometimes he may not be on any anticoagulants, and suddenly patient develop breathlessness, or patient may go to respiratory failure. Generally, cardiologist will call, will get call, and generally will suspect for pulmonary thromboembolism. Generally in ECG will see signs like sinus tachycardia, right bundle branch block, and S1Q3T3 pattern. And in echo generally we'll see RARV dilatation. Like even we'll compare the previous echo. If any previous echo is available, we'll see the previous echo and compare with that with the size at the present echo, like RARV size. And sometimes there will be, we can see the thrombus in the pulmonary artery. And even we will see sometimes we may encounter like clot in the RARRV, and there will be decreased TAPSE, and all these things generally will get calls from cardiologists. Generally our intensivist get after, like suddenly patient will collapse after orthopedic surgery after few days, or some cancer patients like adenocarcinoma of pancreas or prolonged flight surgery, generally will give more importance in RV compared to LV in such situations. And even in heart failure patients, generally like when there is acute decompensation of heart failure, to monitor and to escalate the dose of diuretics, will generally will see IVC. And for any valvular surgeries, like when there is severe MS or severe MR, for giving to cardiovascular surgeon, will measure the will grade the pulmonary artery hypertension. And even for any pre-surgical clearances, like generally for any major surgeries, genesthetist will ask for pre-surgical clearances, whether it was moderate, mild, or generally for that pre-surgical assessment will give more importance to the RV for measuring right ventricular systolic pressure. Generally, if RVSP is high, when they intubate, extubation will be difficult for the anesthetist. So, in general, serially right ventricular assessment or right ventricle function was easy compared to left ventricle if you go in a systematical manner. Like first you have to start with views, like first you go with parasternal long axis, parasternal short axis, apical 4 chamber, apical 5 chamber. See the all these structures, and you can serially measure. First you can start with for beginners better to start with apical 4 or 5 chamber and measure, start practicing with TAPSE. TAPSE is most easy way to, for the beginner, even for me it is most easy way to measure right ventricular function. And simply if you get any apical 4 or 5 chamber view, you can place a color doppler or the tricuspid valve and you can see the TRV max, and after that you can measure the RVSP. And for beginners, measurement of IVC also I think it will be easy. Generally by placing patient in supine position, keeping probe in subcostal view, and you can measure you can see IVC, and you can keep an M mode and you can measure IVC. So this I from this I think I can end my session. If any doubts, you can chat or you can talk with me.
Participants, if you have any doubts, please uh,
You can type or you
type.
can give access to them, let them speak with you, or you can chat. I can see your chat. I want you to see. I want you to learn the basic in the assessment of the right ventricle. I want you to. I think after my class, you have to go to your wards or to your respective patients. Kindly practice it. Generally, by listening or by studying, you may not get the code. Generally, you have to practice on the patients. Slowly you'll get, first you have to get with the views, and slowly you'll get the all these things. By practicing only you will get all these measurements and all these things. Oh, 1 minute, I have to uh, okay, someone is asking what is moderator band. Moderator band is nothing but a normal variant present in the RV, like it is like muscle in the RV, like papillary muscle in the RV. See, how to measure RVSP if there is no TR component? If there is no TR component, generally will measure by pulmonary acceleration time. You can see the third image in my slides. We can keep the pulse wave Doppler or the pulmonary artery valve, and you can see pulmonary acceleration time. By see, I will show the pulmonary acceleration time slide to you. See, this was the slide showing pulmonary acceleration. Indirectly, you can measure the pulmonary hypertension by placing a pulse wave Doppler over the pulmonary valve, and you can see pulmonary acceleration time. Generally, pulmonary acceleration time, general mission will calculate once you keep the pulse wave Doppler over the pulmonary valve, and you will get it. Generally, if it is more than 120 milliseconds. If it is less than 120 milliseconds, you will suspect pulmonary artery hypertension. Why pacing is done in on right ventricle? generally will place lead generally will place lead from subclavian vein to the like subclavian vein to right atrium, then it will be placed in the right ventricle. I don't know how to answer why pacing is done on right ventricle is uh, will pace over the RV apex. So it is easy to get a venous axis, and generally pacing is done in right ventricle only. Someone didn't understood about TAPSE. TAPSE, see, for TAPSE generally you have to take apical 4 or 5 chamber view, and you have to take M mode. There will M mode in the 2D echo, and you have to place M mode over the tricuspid valve, and you will get uh, motion mode of the tricuspid valve, and you have to measure the distance. RV dimension generally you have to measure at the level of the annulus, and at the mid level, and from tricuspid valve annulus towards the apex also. See, Doctor. Generally, TAPSE if it is less than 16 will consider it as severe RV dysfunction. See, I will show the TAPSE slide one minute. See, here we got apical 5 chamber view, and motion mode M mode we kept at the level of tricuspid valve, and after placing M mode you will get like M mode of the at the level of tricuspid valve, and you have to measure distance like this. You have to measure. How to explain it? Like you have to measure the amount of longitudinal motion of the annulus at the level of peak systole. Like you have to, I think you have to demonstrate it by video. I think it will be better to you to understand TAPSE. Yes, through 2D echo can you measure RV? Yes, you can measure RV wall thickness even with 2D echo by placing, by getting subcostal view, and you can apply motion M mode or the right ventricle, and you can get the uh, right ventricular wall thickness. Any further queries? Difference between parasternal long axis view and parasternal short axis view. Um, See, I have to show you the. See, first image which was showing in the slide, first image was showing parasternal long axis view, plaques view. See, generally in parasternal long axis, you will see LA, mitral wall, LV, aorta, and right ventricular outflow tract. Uh, and for parasternal uh, short axis view, generally we'll see right ventricle, generally parasternal long short axis will see at the level of mitral valve and at the level of papillary muscle and at the level of apex. Generally we'll see parasternal short axis view with RV, interventricular septum, and left ventricle. And RV will see anterior wall, lateral wall, and inferior wall. The second row, first image. Yes, if intratrial septum booming towards RA, yes, sometimes maybe it is septal aneurysm. Yes. And again, they're asking about TAPSE. See, for TAPSE, generally we have to get apical 4 chamber view or apical 5 chamber view, and you have to see the tricuspid valve, and you have to place M-mode cursor over the tricuspid valve, and you have to measure TAPSE.
If there is no any further questions, we can end the session, doctor.
Yeah, I think we have to wait for few more minutes. Let them.
Okay.
Yeah. Difference between 2D and M mode. Generally, in 2D, you'll get the like how to say in simply in vague terms, like we'll get the like 4 chambers of the heart. In M mode, like in like we'll get in like barcode, like small lines. Like M mode, we call it as motion mode. Is this session useful to you? You understood what I have conveyed to you, so that so are any further queries to improve my session, like how to improve from my side?
Hello, sir. Hello, sir.
Hello.
Good evening, sir. Can I ask something?
Yeah, yes.
So I'm working in the ICU intensivist. So we are generally usually do a four chamber view, very common, just to screen that heart function initially before the cardiologist come at the.
Yes.
Can you little me give a detail about that other view, how to conduct and the location, because sometimes with paraseptal view is confused in some features like endocarditis and endo pericardial effusion, how to see. We can't understand the properly that septal view and all. We just understand only for chamber view. So this,
Generally, you have to generally you have to start with parasternal long axis view. Even any echocardiographer generally they will start with parasternal long axis view. And generally you have to keep I think I have to show you the video rather than speaking in with these audios, but generally you'll get all the views generally by practicing only. You have to continuously practice to get the all the views. Generally, for getting parasternal long axis, you will keep probe or the second intercostal space adjacent to the sternum, but it was may not be true for everyone. Any further queries?
sir, which view is good to assess the arrhythmia during the study, sir?
Which view to assess arrhythmia during study, like echo study?
Yes, sir.
By experience only you will get generally in every view you can detect atrial fibrillation. In parasternal long axis view you can detect, even in apical 4 or 5 chamber you can see like VPCs like ectopics during study, and like atrial fibrillation during study. I think by experience you can get that, and you can correlate with ECG also. I think better for assessment of arrhythmias generally will assess in ECG compared to 2D echo. Uh, by experience, maybe you can detect even in 2D echoes. Like generally, if you want to detect arrhythmias in the in 2D echoes, generally practice in ICU patients when atrial fibrillation episode was going on. Like generally, most commonly when you can see in atrial fibrillation with fast ventricular rates, you can generally see. You can find the arrhythmias in like beating of the heart in the 2D echo. Try to practice ICUs with atrial fibrillation with fast ventricular rate, and you have to practice in the normal sinus rhythm patients. You can observe that changes.
Okay, sir.
But
Thank you.
but but my side better to see arrhythmias in the 2D echo or in Holter compared to, sorry, in ECG or Holter compared to 2D echo. I
Yes.
think it may require some experience for monitoring of arrhythmias in the 2D echo.
Yes, sir. Obviously, ECG is very important. Sometimes we can miss the MI on the ECG, but we can pick it up in especially 2D echo while regional motion wall abnormalities.
Yes, yes.
Thank you. Thank you, sir.
Generally, for RV assessment, even we can assess most common generally in ICU situations we'll encounter RV assessment most commonly in like pulmonary embolism is one of the scenario, and second thing any mass or any thrombus, and third thing generally we'll call generally cardiology will be called for any vegetations, and fourth thing was in like inferior wall MIs. There
Yes.
will be RV ischemia. Generally, we'll assess RV function in the inferior wall MIs.
Yes, sir. Thank you so much, sir. It's a really nice session, sir.
I think whatever the thing I have told, I think from my side, you have to apply your knowledge and you have to improve. I think critical care people were more worried about right ventricle compared to left ventricle.
Yes, sir. You are right, sir.
And try to practice it. I think you will get, and try to read as many echo books as you can, and not only reading the books will help in getting 2D echo images or applying 2D echo knowledge. Try to practice it on every patient so that you will be updated and your skill will be improved. RV wall thickness helpful in RV failure? Generally, no. Any questions? If no further queries, we may end the session. FAC is nothing but fractional area change.
Doctor, I think we can end the session.
Yeah, thank you. Thank you very much.
Thank you, Doctor. Thank you for the wonderful session. So for the participants, I'll be sending you the feedback form. Once the feedback form, after you fill the feedback form, automatically the participation certificate will be sent to your mail. I'll send the link in a chat box. Thank you, Doctor.
Thank you. Thank you. Please end the session.